Good day, everyone. I am Shalu Jaisal. I am here to continue the report about bipolar and related disorders. The topic outline. First, what is substance or medication induced bipolar and related disorder? Substance or medication induced bipolar disorder is classified as mania, hypomania, or major depressive episode directly caused by a substance or medication that is or has been taken. The diagnosis will be dependent on the individual's personal mental health history as well as the nature of the substance or medication taken. These changes in mood must be prominent and persistent in order to be classified as substance or medication induced. The symptoms must also start during or soon after the substance or medication was taken or during withdrawal. The diagnostic criteria for substance or medication induced bipolar and related disorder: A. A prominent and persistent disturbance in mood that predominates in the clinical picture and is characterized by abnormally elevated, expansive, or irritable mood and abnormally increased activity or energy. B. There is evidence from the history, physical examination, or laboratory findings of both 1 and 2. 1. The symptoms in criterion A develop during or soon after substance intoxication or withdrawal or after exposure to or withdrawal from a medication. 2. The involved substance or medication is capable of reducing the symptoms in criterion A. C. The disturbance is not better explained by a bipolar or related disorder that is not substance or medication induced. Such evidence of an independent bipolar or related disorder could include the following: the symptoms precede the onset of the substance or medication use. The symptoms persist for a substantial period of time, like for example about 1 month after the cessation of acute withdrawal or severe intoxication. Or there is other evidence suggesting the existence of an independent non-substance or medication-induced bipolar and related disorder. Like for example, a history of recurrent non-substance or medication-related episodes. D. The disturbance does not occur exclusively during the course of a delirium. E. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Prevalence. Limited epidemiological data exists regarding the prevalence of substance or medication-induced mania or bipolar disorder. Prevalence of substance-induced bipolar disorder will depend on substance availability and level of substance use in a society. For example, countries with cultural prohibitions against alcohol or other substance use may have a lower prevalence of substance or related disorders. Next is bipolar and related disorder due to another medical condition. What is it? Bipolar and related disorder due to another medical condition is a mood disorder diagnosis given when there is a prominent and persistent period of abnormally elevated, expansive, or irritable mood and abnormally increased activity or energy that is attributable to another medical condition. Medical conditions commonly known to cause bipolar mania or hypomania include Cushing's disease, multiple sclerosis, stroke, and traumatic brain injuries. In particular, for Cushing's disease, once it is cured or in remission, the hypomania or mania typically will not recur. So, the diagnostic criteria for bipolar and related disorder due to another medical condition. A prominent and persistent disturbance in mood that predominates in the clinical picture and is characterized by abnormally elevated, expansive, or irritable mood and abnormally increased activity or energy. B. There is evidence from the history, physical examination, or laboratory findings that the disturbance is the direct pathophysiological consequence of another medical condition. C. The disturbance is not better explained by another mental disorder. D. The disturbance does not occur exclusively during the course of a delirium. E. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or necessitates hospitalization to prevent harm to self or others, or there are psychotic features. Specify if, with manic features, full criteria are not met for a manic or hypomanic episode. With manic or hypomanic-like episode, full criteria are met except criterion D for a manic episode or except criterion F for a hypomanic episode. With mixed features, symptoms of depression are also present but do not predominate in the clinical picture. Causal factors in bipolar disorder. So, bipolar disorder can have several causes. Researchers studying bipolar disorder over the past decades have several theories to explain how this condition develops. Existing evidence points to a range of possible causes rather than one specific cause. So, experts believe bipolar disorder usually develops from a combination of the following factors: biological causal factors and psychological causal factors. So first is biological causal factors. A number of biological factors are thought to play a causal role in the onset of bipolar disorder. These factors include genetic, neurochemical, hormonal, neurophysiological, neuroanatomical, and biological rhythm influences. So first is the genetic influences. Bipolar disorder tends to run in families. According to the recent edition of the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5-TR, genetic processes strongly affect predisposition to bipolar disorder, with heritability estimates around 90% in some twin studies, and risk of bipolar disorder in the general population is around 1%, while risk in a first-degree relative is 5 to 10%. However, monozygotic concordance rates are significantly less than 100, so 40% to 70%, indicating that much risk is left unexplained by genes alone. The mechanism of heritability is not Mendelian and involves multiple genes or more complex genetic mechanisms of small effect interacting with each other the environment, and random factors. Emerging genetic findings suggest that mania and depression proneness are inherited separately, and bipolar disorder shares a genetic origin with schizophrenia. So, next is the neurochemical factors. Experts believe that bipolar disorder is partly caused by an underlying problem with specific brain circuits and the functioning of brain chemicals called neurotransmitters. The three brain chemicals, norepinephrine or noradrenaline, serotonin, and dopamine. These three brain chemicals are involved in regulating our mood states. The biogenic amine theory hypothesizes that if depression is caused by deficiencies of dopamine, serotonin, and norepinephrine, then perhaps mania is caused by excess of these neurotransmitters. So, next is abnormalities of hormonal regulatory systems. Some neurohormonal research on bipolar disorder has focused on the HPA axis or hypothalamic pituitary adrenal axis. So, cortisol levels are elevated in bipolar depression, but they are usually not elevated during manic episodes. Similarly, people with bipolar disorder who are in a depressed episode show evidence of abnormalities on the dexamethasone suppression test at about the same rate as do people experiencing in unipolar depression. And these abnormalities persist even when the patients have been fully remitted and asymptomatic for at least 4 weeks. Next is sleep and other biological rhythms. So, there is a considerable evidence regarding disturbances in biological rhythms such as circadian rhythms in bipolar disorder. So during manic episodes, patients with bipolar disorder tend to sleep very little, seemingly by choice, not because of insomnia, and this is the most common symptom to occur prior to the onset of a manic episode. So during depressive episodes, they tend toward hypersomnia or too much sleep. Even between episodes, people with bipolar disorder show substantial sleep difficulties, including high rates of insomnia. Next is neurophysiological and neuroanatomical influences. So with PET scans, it is possible to visualize variations in brain glucose metabolic rates in depressed and manic states, although there is far less evidence regarding manic states because of the great difficulties studying patients who are actively manic. Several summaries of the evidence from studies using PET and other neuroimaging techniques show that whereas blood flow to the left prefrontal cortex is reduced during depression, and during mania, it is increased in certain other parts of the prefrontal cortex. Several recent reviews suggest that there are deficits in activity in the prefrontal cortex in bipolar disorder. These seem related to neurophysiological deficits that people with bipolar disorder show in problems solving, planning, working memory, shifting of attention, and sustained attention on cognitive tasks. There are many studies on neurophysiological and neuroanatomical influences in bipolar disorder. However, it is hard to draw firm conclusions in this area because there are many inconsistencies in the results across studies. Next is the psychological causal factors. Although biological factors play a prominent role in the onset of bipolar disorder, psychosocial factors have also been found to be involved in the etiology of the disorder. In particular, stressful life events, poor social support, and certain personality traits and cognitive styles have been identified as important psychological causal factors. So, stressful life events. Both stressful life events during childhood, like for example, physical and sexual abuse, and recent life stressors during adulthood, like for example, problems with friends and partners, financial hardship, increase the likelihood of ever developing bipolar disorder as well as having recurrences. Other psychological factors in bipolar disorder. So, other social environmental variables may also affect the course of bipolar disorder. Like, for example, one study found that people with bipolar disorder who reported low social support showed more depressive recurrences over a 1 year follow up, independent of the effect of stressful life events, which also predicted more recurrences. There is also some evidence that personality and cognitive variables may interact with stressful life events in determining the likelihood of relapse. Like for example, the personality variable neuroticism has been associated with the symptoms of depression and mania, and two studies have found that neuroticism predicts increases in depressive symptoms in people with bipolar disorder. So, treatments and outcomes of bipolar disorder. There are three categories for the treatments of bipolar disorder. So first is the pharmacotherapy. Antidepressant, mood stabilizing, and antipsychotic drugs are all used in the treatment of bipolar disorders. So first, how antidepressant work? Antidepressants increase the number of neurotransmitters in the brain. These feel-good chemicals can lift a person's mood, reducing depressed feelings. So examples of neurotransmitters include serotonin, norepinephrine, and dopamine. Depression in bipolar disorder can be severe and may even cause suicidal thoughts. While antidepressants can help relieve symptoms of depression, they do not help with bouts of mania. For this reason, antidepressants are not always the most effective treatment for people with bipolar disorder. So, the use of antidepressants for bipolar disorder has also been controversial because antidepressants have triggered manic episodes in a small percentage of people with the condition. So next is lithium and other mood stabilizing drugs. Lithium therapy has now become widely used as a mood stabilizer in the treatment of both depressive and manic episodes of bipolar disorder. So the term mood stabilizer is often used to describe lithium and related drugs because they have both anti-manic and antidepressant effects. That is, they exert mood stabilizing effects in either direction. So, stated earlier that treatment with antidepressants is associated with significant risk of precipitating manic episodes or rapid cycling, pero the risk of this happening is reduced if the person also takes lithium. So, evidence has emerged for the usefulness of another category of drugs known as the anticonvulsants in the treatment of bipolar disorder. So, these drugs are often effective in patients who do not respond well to lithium or who develop unaccessible unacceptable side effects from it, and they may also be given in combination with lithium. However, a number of studies have indicated that risk for attempted and completed suicide was nearly 2 to 3 times higher for patients on anticonvulsants medication than for those on lithium, suggesting one major advantage of giving lithium to patients who can tolerate its side effects. So, both people with bipolar or unipolar depression who show signs of psychosis, like hallucinations and delusions, may also receive treatments with antipsychotic medications in conjunction with their antidepressant or mood stabilizing drugs. Next is the alternative biological treatments. So first, let's talk about electroconvulsive therapy. So, electroconvulsive therapy or ECT is often used with patients who are severely depressed, especially among the elderly, and who may present an immediate and serious suicidal risk, including those with psychotic or melancholic features. It is also used in patients who cannot take antidepressant medications or who are otherwise resistant to medications. So, the most common immediate side effect is confusion, although there is some evidence for lasting adverse effects on cognition, such as amnesia and slowed response time. Maintenance dosages of an antidepressant and a mood stabilizing drug such as lithium are then ordinarily used to maintain the treatment gains achieved until the depression has run its course. ECT is also very useful in the treatment of manic episodes. Reviews of the evidence suggest that it is associated with remission of marked improvement in 80% of patients with mania. Maintenance on mood-stabilizing drugs following ECT is usually required to prevent relapse. So next is transcranial magnetic stimulation, or TMS. TMS is a non-invasive technique allowing focal stimulation of the brain in patients who are awake. So during an TMS session, an electromagnetic coil is placed against your scalp near your forehead. The electromagnet painlessly delivers a magnetic pulse that stimulates nerve cells in the region of your brain involved in mood control and depression. It's thought to activate regions of the brain that have decreased activity in depression. Moreover, TMS has advantages over ECT in that cognitive performance and memory are not affected adversely and sometimes even improve as opposed to ECT, where memory recall deficits are common. Finally, TMS appears to be safe for use with children and adolescents, with only low rates of mild and transient side effects such as headaches and scalp discomfort. Next is deep brain stimulation. So what's the difference between TMS and deep brain stimulation? So TMS uses non-invasive magnetic stimulation to safely activate and strengthen the brain's communication channels. Deep brain stimulation, on the other hand, is a surgical procedure where electrodes are planted directly onto the brain. So deep brain stimulation has been explored as a treatment approach for individuals with refractory depression who have not responded to other treatment approaches, such as medication, psychotherapy, and ECT. So the deep brain stimulation involves implanting an electrode in the brain and then stimulating that area with electric current. Next is psychotherapy. So, cognitive behavioral therapy or CBT is a type of psychotherapy but can be used to help manage bipolar disorder. Psychotherapy may involve, or the CBT may involve in a one-on-one interaction with a therapist. It may also involve group sessions that include the therapist and other people with similar issues. This can reduce overall distress and decrease manic or depressive episodes. It can also create awareness of one's mood, emotions, physical sensations, and common indicators of a manic episode. The behavioral activation treatment. This treatment approach focuses intensively on getting patients to become more active and engage with their environment and with their interpersonal relationships. These techniques include scheduling daily activities and rating pleasure and mastery while engaging in them, exploring alternative behaviors to reach goals, and role playing to address specific deficits. Traditional cognitive therapy attends to these same issues but to a lesser extent. Behavioral activation treatment, by contrast, does not focus on implementing cognitive changes directly but rather on changing behavior. So next is the interpersonal therapy. IPT or IPT. IPT is an add-on therapy for treating bipolar disorder and other mood disorders. The therapy aims to minimize disruptions to your daily routines and rhythms since these changes can lead to disrupted sleep, and an unstable mood in some people. So, IPT can help to minimize the impact of stress from relationship conflict. During sessions, your therapist will also examine the impacts of stressful, role changing life events such as marriage or divorce, getting a new job or losing a job, and having a child. Next naman is family and marital therapy. So family-focused therapy is a hybrid of two forms of psychotherapy. It is both a variety of psychoeducation or a type of therapy whose main goal is to teach patients and their families about the nature of their illness. Yun lang po. Thank you.